The session that this is in fact a special oncology plenary. In fact, it's got a superhero session, a sort of feel to it, and it's really about superhero and superpowers. Because, you know, I'm so proud of Australia. It's a superpower in terms of the trials that it's run in Theranostics, and it's done that because of our superheroes, but also because of everyone who's here in this room today and everyone who's been involved in all of the trials we've been running around Australia. So just before we start, I also have a superhero, and she actually said, "You're never too small to make a difference." I don't know if you know who that is. She also has said her disability was her superpower. You know, I take a lot from that. I think we can all learn a lot about being humble, being collaborative, and everyone can be involved. But with this real superhero today, who's going to be our first speaker, he's just done so much for Australia in terms of his collaboration, his trials, and his generosity. I first met Michael nearly 10 years ago when I went to Peter MacCallum, and I asked him for his protocol so that I could do a trial in lutetium PSMA. I don't think he knew who I was. I don't think he'd ever seen me before, and he was so generous, and it's just led to a great friendship. So without further ado, I'd like to invite our first superhero, Professor Michael Hofman from Peter MacCallum.
Thanks, Louise. For those who didn't recognise, Louise is Greta. Thanks for the invitation to give this talk. I do have a very big conflict of interest to declare before I start. The images generated in this talk have been done using an artificial intelligence deep learning tool called Midjourney. So have a play with it if you want to do some of this stuff. But we'll start with a real image. This is really the superhero of Theranostics, Saul Hertz, who back in the 1930s, when medical cyclotrons were being invented and he was trying to understand thyroid physiology, asked the physicists making radioactive substances whether they could make radioactive iodine, and they made him radioactive iodine, and he treated the first patients both for benign thyroid conditions and then for malignant thyroid disease, and he, at the time, he recognised that his discovery could be used for many other technologies beyond thyroid cancer, and he had this quote: "My new research project is in cancer of the thyroid, which I believe holds the key to the larger problem of cancer in general." Now, I put this into the AI algorithm and it colourised it for me, so that's one of the first times you've seen this picture in colour. Most people think this is a patient with Graves' disease, but it's actually his assistant who just volunteered to pose, and we can now sharpen this image and see it even in more true life. This is a record of the first 20 cases that he cured with radioactive iodine in his handwriting, and there's a really strange coincidence, because in 1938 Superman first appeared in Action Comics, and in fact that's exactly the same year that Saul Hertz published his landmark paper on radioactive iodine as an indicator in the study of thyroid physiology. So do you think this is just coincidence, or is there, maybe there's more to it? And I think if Saul Hertz at the time, he couldn't image, so he could give the radioactive iodine and he could track it with his multiscaler or gamma counter externally, but there was no imaging technology, so he just had to sort of visualise it in his head. But if he did have a PET scanner, he would probably picture it looking something like this. In fact, we're just installing a new Siemens PET scanner in Peter Mac. It's going live next week, a Vision. Maybe we should make it superhero themed. He might have envisioned it like this. This is actually how we took out the old PET scanner. But Superman himself, you know, it's difficult for him to have scans because the X-rays, they don't actually pass through his body. But he probably would have never guessed that we now image in the Superman position all the time. But in all seriousness, Saul Hertz's discovery in the 1930s with radioactive iodine, the first question I asked my registrars or fellows on day one, I ask everyone this, so for those in the audience who have experienced it, I asked them what's the best tracer in nuclear medicine, and most people say FDG, then they progressed maybe to dotatate, then to PSMA, but it's actually radioactive iodine. It's still the best tracer we have, and the best tracer has the highest tumour to background contrast. And this is an I124 PET scan, so the positron-emitting version of radioactive iodine. And we get astounding SUVs. These are tiny lymph nodes in the mediastinum, SUV max 430. And these correspond to sub-millimetre lymph nodes on CT. And when you see thyroid bed activity with star artefact, if you do an I124 on those patients, you often get SUVs of 3,500. I've even seen SUV max 4,800. So this is the best tracer we have to date. Nothing competes. Dotatate PSMA has like an order of magnitude less target to background. So it's not surprising that we've been able to cure patients with metastatic thyroid cancer for some time. Here's an example of this on I124 PET. And on the 6-month follow-up PET, I've had to put the blue outline based on the CT because there's actually just no uptake on the scan. It's such a good scan that there's literally no background activity. These are windowed 0 to 50 SUV. So all of us in the audience are familiar with Theranostics, the concept that we're combining a diagnostic and a therapeutic radio tracer. So I won't labour on this. Lutetium-177 has become our mainstay, and it's like a bit of unlike the targeted drugs in modern oncology where resistance often rapidly develops, this 1 millimetre path length leads to a cluster bomb type effect or a crossfire effect where every cell in the tumour is bombarded with beta radiation, and even cells that aren't expressing the target receive very high doses of radiation. So this is true for radioactive iodine, the beta path length being very similar to lutetium-177. Lutetium being a radiometal is much easier to label via some chelators to other molecules. We'll hear from Mo Haskali on that coming up. So this is a chart of FDA-approved radio tracers, and we can see the time of first use and then the date of FDA approval. And you'll see radioactive iodine FDA approved in 1951. Lutetium dotatate first used around 2000, then took back 20 years to get FDA approved. And remarkably, lutetium PSMA happened in 9 years, first used around 2013 and FDA approved last year. So my fascination with Theranostics really began with lutetium dotatate for neuroendocrine tumours after I arrived at Peter Mac some 13 years ago. And this was a case presented at the MDT, a very aggressive pancreatic neuroendocrine tumour with a Ki-67 of 50%. I remember being at the multidisciplinary meeting and they were presenting the second image. After 3 cycles of chemotherapy, the tumour volume had doubled on PET imaging, so it was pretty obvious that the chemotherapy wasn't working. And I suggested, well, let's switch the patient to lutetium dotatate. And the vibe in the MDT was, if they've had this response to chemotherapy, they're not going to respond to anything, Michael, but if you really want to try it, you can. And when we treated the patient, they had a pretty exceptional response. And after 4 cycles of PRRT, just a small amount of tumour left in the pancreas and a complete response elsewhere. But what happened to this patient over the next 10 years is just as remarkable because he had relatively stable disease for about 3 or 4 years after lutetium therapy. And then when he did recur, which I think is actually in 2019, then we gave him further lutetium and he kept on responding for around a decade, receiving 11 cycles of lutetium and some yttrium-90 dotatate in total. And this is not an unusual event. This is quite representative of many of the patients that are coming to our centre. And more recently, the platform that we had at Peter Mac with gallium generators, radiopharmaceutical scientists that knew how to label to lutetium enabled us to switch very early on to PSMA as a target when we saw some data coming out of Germany that was very promising. And my Superman moment actually occurred in, Louise bought me this Superman outfit. My Superman moment, it occurred in 2018 in Philadelphia at the Society of Nuclear Medicine meeting, because there was an awards ceremony and rumour had spread that an Australian had won the Society of Nuclear Medicine Image of the Year. And Professor Chris Rowe, who's in the audience somewhere, had got wind of this. And, he's one of the most highly cited nuclear medicine doctors in Australian history. And he had an amazing abstract on tau imaging in dementia. I think I've got that right. And he was 100% sure that he had won the award. So he was ready to stand up at the award ceremony. And then they said, the winner is, this is a true story, and they showed this image, and it was our image from our first prospective trial of lutetium PSMA from Peter Mac, showing the best 8 responders before and after with gallium PET imaging. And that's when it was pretty clear to me that Theranostics is better than tau imaging. Thanks to ANSTO, we were able to really do this first trial. ANSTO kindly provided us with, free lutetium for that first 30-patient trial. Otherwise, it really wouldn't have been possible. And we're very lucky to have a facility in Australia that can manufacture lutetium. And when you think about the supply chain, from manufacturing lutetium all the way to the hospital, the radiopharmacy, into the patient, it's quite astounding. And we didn't stop there, because then we did the first randomised trial of lutetium PSMA compared to chemotherapy, which was the therapy trial that Louise Emmett was also pivotal, and many people in this room pivotal at doing. And it really supplemented the VISION trial done by Novartis in leading to global availability of this compound. So this trial, published in The Lancet only 2 years ago, has led to, or contributed to, FDA approval, and leading to current evaluation for funding in Australia, and has helped optimise the sequence of when best to use lutetium in the management of prostate cancer patients. And as Louise alluded to, this was really a pretty incredible Australian effort. We had nuclear medicine doctors at 11 sites, together with tech teams, radiopharmacy teams, working really closely with medical oncology, urology, clinical trials teams, radiation oncologists to make this happen. And it really needs a village to make trials like this work. But it also relies on individuals like Louise. This is when I first visited Louise in her office. I actually caught her looking like this, I'm not joking. She looked very serious. She was on a mission. And she said, "We will make lutetium PSMA available to men who need it." And when I went back in the archives, Louise is not that different to Greta. In fact, I've got this photo of her talking when she was a medical student. She was already giving lectures on Theranostics, and she was telling the crowd how Theranostics is wonderful because it's a really personalised treatment. We don't just give it to everyone like chemotherapy. So she was showing these types of images in medical school. On the left, a PSMA PET, in the middle, an FDG PET, and then we can colour code these and show our patients why we don't want to treat them. Around 1/3 of the patients that we screen in our centre, we think are not optimal for lutetium PSMA, so we think very hard about whether they should have an alternative oncologic treatment. And our ability to visualise how much of the disease we can target with lutetium versus how much we can't. In this case, all the disease in red is not expressing PSMA, and that's predominantly in the liver, but also in bone. Leading on from that therapy trial, we now have more than 10 physician-led, investigator-initiated trials underway in Australia using lutetium PSMA, which I'm sure is more than really any other country or multiple countries combined. And the focus has been on moving it from a last line of treatment, where we know it's very effective, to an earlier line of treatment, and also trying various combinations. Here's Superman in our radiopharmaceutical sciences laboratory playing with some alpha and Auger emitters that we think might be the future of nuclear medicine. And there's a whole bunch of these that are either commercially available or, almost commercially available. And there's some early results that are quite striking, such as this image of actinium-225 PSMA, showing a remarkable response in a patient that has failed lutetium therapy. But I do want to note that this was published in 2018 and we're now in 2023, and this is still not an accepted treatment, and there's still not a single prospective trial of actinium-225. And our oncologists rightfully kind of dismiss these images, because for every one of these N equals 1, there may be another 100 patients who had actinium who didn't benefit. So we really need to study this properly and do prospective trials when we've got new novel treatments. Otherwise, even if they are very effective, they'll never become widely available. So I quite like this trial out of the US of lead-212 dotamtate, which is equivalent to lutetium dotatate, but labelled to the alpha emitter lead-212, and it's a prospective series showing some remarkable responses in a series of 10 patients, and this is now being taken forwards to larger trials. At Peter Mac, we're currently playing with terbium-161, which is a dual Auger beta emitter. So terbium has a beta particle very similar to lutetium-177, similar path length, similar energy, slightly shorter half-length, but it also emits this Auger electron that travels less than the width of a cell, and it has an energy not quite of an alpha, but an order of magnitude higher than lutetium, so it's very effective at targeting small volume disease, and we think this may be more effective than lutetium. We've treated, I think, 9 patients at Peter Mac with this year. This is Superman when he got a little bit older. You can see his grey hair, and he actually has, unfortunately, he's got prostate cancer and it's metastatic. And he's being worked up at Peter Mac for a clinical trial just last week. And he met all the inclusion-exclusion criteria, so we thought we were going to enrol him, but he needed the bloods. And the needle, it won't pierce his arms because his skin's as strong as steel. So he's not treated, but we decided we'll just give him compassionate access lutetium on spec. And here is our technologist giving the treatment, because our technologists, and there's many of them in the room, you know, they're the real superheroes, because without them we can't do any of this. So I thought I'd play a little clip to hear from our techs.
I say I can't believe that I'm actually a part of a team that's been able to do some of the things that we are doing. And it's especially rewarding when you'll do a PET scan for a patient who's had, say, lutetium dotatate therapy or lutetium PSMA therapy, and they come back for a scan and you can just see that their disease is completely gone.
More often than not, it's a really good story at the end of it where they get better. That's really meaningful to me, and that's part of why I work here. They achieve things in their life because of what we do.
And that's a really good thing about Peter Mac. Something that makes us really lucky is that we can see that whole process, and we do these novel traces and we do this clinical research that not many other places do. So it's a really good opportunity.
I just feel like things are evolving and changing, and new things, you'll see them here first.
You see the same people coming back and you hear about how they're seeing their grandchildren's 21st, or they've booked a trip overseas, and then you go home and you just think, I'm so lucky, like, you know, there's people that have been through a lot and they've spent years coming in and out of hospital, and I get to sort of look after them and make their journey a little bit pleasant, not scary. Do our best job.
In 2016, we had the pleasure of hosting the 4th Theranostics World Congress in Melbourne, and Barbara Hertz, who's Saul's only surviving daughter, flew out and did a little presentation and had a stand. She's trying to pass on the history and legacy of her father to the next generation. And I met her again in Japan last year at the World Congress of Nuclear Medicine and Biology, and she handed me a gift, and it was actually Saul Hertz's pen. She's got no one else to pass on to all of some of Saul's property that she found in the attic, and she gave me his pen engraved with his name, which was, you know, gave me a real warm, fuzzy feeling. So I have that at home. It's in a real special place. Sometimes I put it in my suit pocket when I'm doing grant interviews and things like that. It's like a good luck charm. But, you know, let's come back to radioactive iodine being the best theranostic, because Andrew Scott is running an MRFF trial around Australia called the I-FIRST trial. And I wasn't surprised, because Andrew's usually first in most things that happen. I wasn't really surprised that he called the trial I-FIRST. And in this trial, he's trying to give radioactive iodine to patients who won't benefit. So it's a strange kind of trial. This is a patient recently recruited at Peter Mac in Andrew's I-FIRST trial. This patient's got metastatic thyroid cancer, and you can see the I-124 PET scan, and there's very, very little uptake in this large pulmonary metastasis. And in fact, this patient's got lots of metastases, and none of them take up much iodine except for a very few small ones. So it really takes a superhuman effort to try to treat this patient with radioactive iodine. It takes, you know, someone like this to come up with an idea. And in this trial, patients get 4 weeks of a drug to redifferentiate the thyroid cancer so that they re-express the sodium iodine symporter. This is a BRAF MEK inhibitor. And this patient had 4 weeks of treatment. And here's the I-124 PET scan 4 weeks later. SUV max in that lung nodule has gone from 8 to 730, which is really quite astounding. And that's the I124 PET at 24 and then 48 hours. And that's the SUV at 48 hours. And you can see the remarkable redifferentiation that's occurred. And this patient has gone on to have I131, and no doubt with SUVs of almost 1,000, this patient's going to have a great response to therapy. So I think we need to think about how we apply this to somatostatin receptors and PSMA receptors as well. How can we upregulate that? And with that, come to my last slide. Theranostics is not new. It's been around for over 80 years. There's many different words used to describe theranostics summarised in this slide. I'd like to thank Superman for his superhuman effort and Louise for giving me this top. Thank everyone at Peter Mac who's involved in the program, all our funding partners and collaborative partners, and just a little advertisement for our prostic preceptorship, which is running next year, March 14 to 16, which is a teaching course both on the imaging and therapy side. Thank you.
Fantastic.